All right, welcome back. Chapter 13 Pharmacology's Principles Thereof. We're going to move forward with Lecture 2, which begins on slide 37 of the focus slides. And we're going to talk about the mechanisms and types of responses that medications give, and then the routes that we can give them. So, here we go. All right, so medications can alter cell function without interacting with receptors sometimes. So, they alter cell tissue, organ, and brain system function. They're engineered specifically to target other sites throughout the body, such as microorganisms, lipids, water, and exogenous toxic substance that may enter the body itself. All right, so targeting of specific substances present in the cell walls of a bacteria or fungi, such as antibiotics and also antifungals. Then we have chelating agents. They bind with heavy metals, such as lead, mercury, and arsenic. They create a compound that can be eliminated usually through the body or natural processes. Then you also have your sodium bicarbonate, which breaks down after administration, producing bicarbonate ions. Because it binds with excessive hydrogen ions, it raises your pH, and then therefore it decreases the acidity of various body fluids. Then you have diuretics, and you also have electrolyte-based medications. Your diuretics create osmotic changes. Otherwise, we're changing in the amount of water and how we get rid of water and how we take on water. It alters the distribution of fluids and the electrolytes. It draws excess water away from certain body tissues while enhancing the excretion of urine. It also targets water in the body and alters the distribution of various body fluids. Then you have your electrolyte-based medications. They change the concentration and distribution of ions within the cells and fluids throughout the body. They affect the ability of various cells to function. All right, so factors affecting response to medications. They include the choice of medication, the dose, the route, the timing, the manner of administration, and the monitoring. Factors in how medication affects a patient due to weight-based dosing. Number one is age. Medications are distributed into three primary types of body substances: water, lipids or fat, and then proteins. With water-soluble medications, higher weight-based doses must be administered to infants than to adults and elderly people. Fat and lipid-soluble medications require higher weight-based doses in elderly patients. When treating pediatric or elderly patients, consider careful titration of medications rather than administering weight-based dose. Water-soluble and lipid-soluble medications may require increased initial doses to overcome widespread distribution throughout the body. Alteration of metabolism and elimination in both pediatric and elderly patients may prolong the effects of medications or result in higher concentration in various tissues. The cytochrome P450 system affects medications' metabolism within the liver. It works differently on different types of medications. It's extremely variable in infants and children and has a functional decline in elderly people. Also, a decline in liver or kidney function requires a decrease in dosage for many types of medications. Patients at extremes of age are disproportionately prone to paradoxical medication reactions. These patients experience clinical effects opposite from the intended effects from the medication. Weight-based medication dosing. All right, so based on the weight, it has much more advantage, or some advantages, especially depending on the age of the patient. The amount of medication administered is proportional to the size of the patient. It's based in kilogram weight. Manufacturers have already calculated the factors affecting absorption, distribution, metabolism, and rates of elimination at the desired quantity present at target cells or tissues. It can be used to calculate the appropriate medication dose for patients ranging from preterm neonates through large adults. Limitations: you need the patient weight in kilograms. It does not consider alterations in distribution, metabolism, and elimination. It is the basis on patient's ideal body weight rather than actual body weight. So ideal body weight rather than actual body weight. Also, we get factors affecting responses. Environment is a big one. Hyperthermia, otherwise we're too hot, the body's too hot. It may increase metabolism of certain drugs and burn it off before it can be utilized appropriately. It may also reduce the amount of drug returned to the circulation. It also suppresses the function of cytochrome P450 system in the liver. And then hypothermia, it definitely impairs the effectiveness of medications used in traditional cardiac life support. So if the patient is cold, your epinephrine, or your bicarb, your calcium, your amiodarone, all those things are affected by the cold. So hypothermia, we got to warm these patients up for our medications to work appropriately. Then we have genetic factors. You need to be extremely careful when deciding whether to administer medications to patients with specific genetic disorders, such as primary pulmonary hypertension, because it may have an acute decompensation when a vasopressor medication is used, and then sickle cell disease. If we use diuretics, it may cause potentially complicated fatal reactions because they're already dehydrated from the sickle cell. Glucose 6-phosphate dehydrogenase deficiencies. Salicylate medications may precipitate hemolysis, so they're going to have much more problems if you're giving them aspirin. Patients and family members are good sources of information, so make sure that you're getting with them prior to making decisions on what medications you're going to use. Another factor is pregnancy. Many changes take place in the body during this time. Cardiac output and intravascular volume increases dramatically. Hematocrit decreases, respiratory tidal volume and minute volume increase. Inspiratory and expiratory reserve volumes decrease. Gastrointestinal motility decreases. Renal blood flow and urinary elimination increase. And the majority of endocrine glands undergo some degree of change. Each of these changes affect absorption, distribution, and/or elimination of medications. You also need to consider the effect of medication on the fetus. 5 FDA pregnancy risk categories do exist. The 5-category system is being replaced by a more detailed system that uses narrative summaries to convey and prescribing information related to pregnancy, lactation, and risk of medications to male and female users with reproductive potential. All right, so this table shows the FDA pregnancy risk categories. This is on slide 47. Slide 47, it is 11-6, or 13-6, excuse me. This table shows the 5 FDA pregnancy risk categories. This is a continued portion of the same. Then we also have physiological factors that affect response to the medications. That includes pain, anxiety, and overall discomfort can vary from individual patient with the same illness or injury. Medication administration is further complicated by what we call the placebo effect. Therapeutic effects. When we talk about therapeutic effects, each patient has a potential for adverse and toxic effects of any excessive dose. The therapeutic response is pharmacological interventions. They are based and selected on a patient's actual or anticipated illness, injury, presenting complaint, signs and symptoms. The patient's condition should match the use and indicated listed on the profile for any specific medication. Medical directors may also authorize off-label uses for approved medications. And then when protocols or guidelines do not seem appropriate for the needs of the patient, you'll be contacting your medical director for advice or authorization. Medication is administered in a dose intended to produce that desired clinical response. That is your therapeutic effect. Some medications require frequent repeated dosing, titrating, or continuous administration. These medications are capable of demonstrating cumulative action, which is several smaller doses producing the same effect as a larger single dose. Not every medication or situation allows for cumulative action. Adverse medication effects, these are our side effects. Side effect and adverse effect are often used interchangeably. Adverse effects indicates the possibility of serious consequences. Some side effects can also be beneficial. Adverse effects may also be referred to as untoward effects. Adverse effects in clinical changes caused by a medication that are not desired and some degree of harm or discomfort to the patient is caused. Some common adverse effects include nausea, vomiting, sedation, respiratory depression, and dizziness. So you need to consider these adverse effects and whether they're truly going to be beneficial for your patient if they manifest themselves after administration of the medicine. Adverse effects may range in severity from very minor to life-threatening. Cardiomyopathy can be caused by certain antidepressants. Stevens-Johnson syndrome can be caused by certain antibiotics and anti-seizure medications. And then a variety of medications can cause anemia through the bone marrow suppression or direct hemolysis. Therapeutic index in animal testing, and it establishes the following: the median lethal dose, the median toxic dose, and the median effective dose. The median lethal dose, or LD50, is a weight-based dose of medication that causes death in 50% of the animals tested. A median toxic dose, TD50, is the weight-based dose at or above which 50% of the animals tested had toxic effects. And then finally, you have a median effective dose. Therapeutic index is the relationship between the medium effective dose and the medium lethal dose. If there is a large difference, the medication is considered safe. If there is a small difference, the patient needs to be carefully selected and monitored. Immune-mediated medication responses include the following. It's medications and substances in the environment that can cause an exaggerated response to the body's immune system, such as an allergic reaction. Patients who are genetically predisposed have an initial exposure and sensitization to the potential or particular allergen. Therefore, their immune system starts to create antibodies. When the patient is re-exposed to the allergen, the potentially massive cascade of the immune system activity occurs, which causes anaphylaxis. Anaphylaxis can occur days or weeks after initiating a medication. A medication sensitivity may occur following the first exposure to the medication or substance. Treatment is very similar to that of an immune-mediated response. Avoid administering medications to patients who have had a serious reaction to the medication in the past unless the effect was clearly dose-related. Tolerances, medication tolerances. Certain medications have a decreased efficacy when taken repeatedly. Reduces tolerance results from what's we call downregulation. It reduces the number of available cell receptors for a particular medication. The body also compensates for the effects of the medication by increasing the metabolism and or elimination of the medication. Repeated exposures to a medication within a particular class has the potential to cause a tolerance to other medications in that same class. This is what we call cross-tolerance. Repeated doses of a medication within a short time rapidly cause tolerance, which is known as tachyphylaxis. Medication abuse and dependence is another problem. We have two distinct groups of medications and chemicals that are prone to misuse and abuse: stimulants and depressants. Repeated exposure can cause what we call habituation. The normal tolerance to adverse or therapeutic effects are associated with the substance, so they have an abnormal tolerance. Prolonged or significant exposure to these kind of medications can cause a degree of dependence, both physical, emotional, or behavioral need for substances to maintain a level of normal function. Some of the interactions of medications can be marked. Medications do sometimes cause interference, and it is an undesirable medication interaction. Consider the possibility of illicit drugs over the counter and prescribed medication and herbal remedies. This is a major concern when it's incompatibility during administration. When given simultaneously through the same IV tubing, some certain medications will change chemical composition. Some medications will deactivate others, and the medications sometimes require proper IV solutions to be given over a period of time. It is possible for a medication to increase, decrease, or alter the effect of another medication within the body. Those are medication interactions. Some medications just aren't meant to be mixed, period. As the medication is administered, the body begins removing it right away. Duration and effectiveness of the medication is determined by dose, route of administration, and the clinical status of the patient. Pharmacokinetics section of a medication profile states the onset is related to absorption and distribution. Peak is related to absorption and distribution. Duration of the effect is related to medication metabolism and elimination. As the amount of medication nears the cell receptors decreases, the effect begins to decrease. If a medication permanently binds with a receptor site or irreversibly alters the function of a cell, the duration is determined by the body's ability to regenerate new cells. All right, so routes of medication continue. The route of administration must allow delivery of the appropriate amount of the correct drug. It is determined by the following: physical and chemical properties of the medication, routes of the administration available for a patient, and how quickly the effects are needed. Then you have bioavailability, which is the percentage of unchanged medication that reaches the systemic circulation. That is the percentage of unchanged medication that once it's given, it actually reaches the systemic circulation. That's very specifically determined by the route of administration, and it varies by medication except for the IV route. IV route has 100% bioavailability. When you put it in through via IV, it's 100% bioavailable. Irrelevant for medications sequestered in the GI tract. So anything that you're taking orally is based on how quickly that medication will absorb. All right, so oral and orogastric tube and nasogastric tube administration. This is table 13-9. It talks about the factors of GI mobility, the pH or the acidity or the alkalinity of the GI tract itself and in the stomach, and then the presence of food and liquids on how it's going to affect that medication absorption. This is on slide 63 of 177. Then you have endotracheal. We don't consider this as a reliable method any longer. All we're really doing is dumping something down there that is just not necessary. If endotracheal medications must be given, the general rule of thumb is administer at least 2 to 2.5 times the IV dose, and then follow up with a 5 to 10 cc flush with sterile water or normal saline. Then we have intranasal, which was introduced a while back. It's a very, very good method, especially for anti-seizure medications when it's very difficult to start an IV. These are liquid medications that are converted into a mist that's sprayed into one or both nostrils. Absorption is very rapid because it comes in direct contact with the mucous membranes. The bioavailability is close, very, very close to 100% in certain studies. And there's no risk for any needle stick injury for the paramedic. That's the good part. Now, intravenous is the preferred method in a pre-hospital setting. A smaller diameter catheter is inserted to a peripheral or external jugular vein. Medication is administered directly into the systemic circulation with a bioavailability of 100%. Onset is much quicker than medications given orally or through orogastric or nasogastric tubes. The limitations do include the following. Access is difficult in several groups of patients, such as patients who have abused IV drugs, patients who are in profound shock, patients with cardiovascular collapse, and patients with certain chronic conditions. The procedure may also cause pain or infection and is time-consuming, and certain classes such as sympathomimetics can cause pain and also tissue damage when administered via IV. Then you have interosseous. A needle is inserted through the patient's skin and into the bone. The vascular uptake from the bone marrow provides a reliable route for administration of medications and IV fluids. Any medication that can be administered IV can be administered via intraosseous. It generally can also be left in place for 24 hours. It is contraindicated in bones that are fractured because you'll just lose the medication that you're trying to put through it. And it's discouraged when patients have bone disease or other skin infections over the insertion sites. Then you have intramuscular. Intramuscular is a sterile medication that is injected into one of the patient's larger muscles. It's used when IV access cannot be established or when clinical situation requires immediate medication administration. Medications have a bioavailability from about 75 to 100%, and there's a risk for contaminated needle stick if the patient moves suddenly. Confirm the following: the medication is appropriate for IM use and a particular muscle should be used. This particular technique for injection should be used. Then you have subcutaneous. It's similar to IM. The medication is injected into various subcutaneous tissue sites throughout the body, such as the anterior part of the abdomen, just outside the umbilicus, the skin overlaying the triceps. Certain medications are indicated for sub-Q use only, such as epinephrine 1:1000 and insulin. Slower absorption may prevent the adverse cardiovascular effects. You have dermal and transdermal. These are medication patches. Patches commonly contain either nicotine, antiemetics, analgesics, and then nitroglycerin. Then you have sublingual. Nitroglycerin is frequently given the sublingual route. Bioavailability is low and large doses are required. Patients must be conscious alert, and a lack of saliva may also delay that absorption. Then you have inhaled or nebulized. It's inhaled pre-hospital medications are limited to oxygen and antidote, such as amyl nitrate administration. It may assist patients with medications via metered dose inhalers, and then medications may be nebulized within themselves. But the thing is that portion of the medications are lost during expiration and pauses in inspiration. Nebulized medications have a potential also to cause rapid bronchospasms. So bottom line is you shouldn't routinely administer medications such as nebulized medications such as calcium, lidocaine, or other non-traditional medications. Then you have the rectal route. It's preferred over the oral route if the patient is unresponsive, having seizures, vomiting, or unable to swallow oral medications. The medication is usually not subject to first-pass metabolism. Certain medications have greater than 90% bioavailability. Medications should be administered in the lower rectum rather than the proximal whenever possible. Rectal preparations are manufactured in a suppository form. Absorption can be unpredictable. Administering an IV solution rectally using a commercial device, lubricating a feeding tube attached to the syringe, and then lubricated small diameter syringe. Never insert a needle into the patient's rectum. That would be dramatic. Ow. Nope. Then you have ophthalmic. Ophthalmic is generally limited to ocular anesthetic agents to facilitate irrigation of the eyes, and it does carry the possibility of systemic toxic effects. Other methods of medication administration could be through hemodialysis, where blood is pumped through the dialysis machine, exposing the blood to dialysate solution before returning to the patient. And then hemodialysis, the dialysate solution removes toxins, excess electrolytes, and other chemicals. Training for paramedics, they should not use any more routes of administration that they are not trained to use. So be sure that we're only following what routes that we are trained to use. All right, so that's slide 74 of 177. That will end lecture 2. That will end lecture 2 of chapter 13. So we'll go ahead and clock out and clock into test number 2, and we'll see you in about 10 minutes.